Today, I will discuss about rectal mucosal prolapse or rectal prolapse. Rectal prolapse is the exteriorization of the rectal mucosa through the anus. In the unusual occurrence where all the layers of the rectal wall are included, it is called posidentia or rectocele. Most cases of rectal tissue protruding through the anus are prolapse and not polyps. They are not hemorrhoids, intussusception, or other tissue. Most of cases with rectal tissue protruding through the anus are rectal prolapse. Most cases of rectal prolapse is idiopathic. The onset is often between 1 and 5 years of age. It usually occurs when the child begins standing and then resolves by approximately 3 to 5 years of age. When the sacrum has taken its more adult shape and the anal lumen is oriented posteriorly, thus the entire weight of the abdominal viscera is not pushing down on the rectum as it is early in the development. Other predisposing factors include intestinal parasites, malnutrition, diarrhea, ulcerative colitis, severe cough from pertussis, and other chronic cough, Ehlers-Danlos syndrome, meningocele, more often associated with posidentia due to the lack of perineal muscle support. Cystic fibrosis and chronic constipation are also other risk factors. Regarding clinical manifestation, rectal mucosal prolapse usually occurs during defecation, especially during toilet training. Reduction of the prolapse might be spontaneous or accomplished manually by the patient or parent. In severe cases, the prolapsed mucosa becomes congested and edematous, making it more difficult to reduce. Rectal prolapse is usually painless or produces mild discomfort. If the rectum remains prolapsed after defecation, it can be traumatized by friction with undergarments, with resultant bleeding, wetness, and potential ulceration. Regarding treatment, initial evaluation should include tests to rule out any predisposing conditions, especially cystic fibrosis and sacral root lesions. Reduction of protrusion is aided by pressure with warm compression. An easy method of reduction is to cover the finger with a piece of toilet paper, introduce it into the lumen of the mass, and gently push it into the patient's rectum. The finger is then immediately withdrawn. The toilet paper adheres to the mucosa membrane, permitting release of the finger. The paper, when softened, is later expelled. Conservative treatment consists of careful manual reduction of the prolapse after defecation, attempt to avoid excessive pushing during bowel movement, for example, with patient's feet off the floor during bowel movement, use of laxatives and stool softeners to prevent constipation, avoidance of inflammatory conditions of the rectum, and the treatment of intestinal parasitosis when present. If all this fails, surgical treatment might be indicated. Existing surgical options are associated with some morbidities, so therefore medical treatment should always be attempted first. Thank you.